Everyone. Um, Today, our topic for discussion is hemolytic uremic syndrome. So, it is also called as HUS, H-U-S, HUS. So, to start with, hemolytic uremic syndrome or HUS, it's a triad of non-immune microangiopathic hemolytic anemia, which is also called as MAHA. Like in many books, you will find this word MAHA, MAHA, which is microangiopathic hemolytic anemia, as well as thrombocytopenia. And the third thing is acute renal failure. So, hemolytic uremic syndrome is a triad of MAHA or microangiopathic hemolytic anemia, thrombocytopenia, as well as acute renal failure. Now, um, the incidence of this condition is not so much, but what is the importance of this condition is like it is the most common cause of uh, acute renal failure in children. That's make it important. Okay. Now, the important thing over here is uh, children they get hemolytic uremic syndrome most of the time as a result of diarrhea, and the diarrhea which is caused by, again, most of the time E. coli. Okay, so um, you can say it is secondary to this thing, right? So now, of course, like this E. coli, which like I will tell you the name of that strain. This one, this strain or this diarrhea, which is caused by that strain, it is caused by when they come in contact with farm animals or they consume uncooked beef. By the way, it's not the only organism, rather, there are many other organisms. So, when we talk about the etiology of this condition, we call it as diarrhea positive, hemolytic uremic syndrome, as well as diarrhea negative hemolytic uremic syndrome. So, 90% of the time, 90% of the time, this is the uh, one. So, uh, they get it from E. coli. It is called as 015787 strain. Though it can be caused by Shiga toxin, it can be caused by uh, others as well. Okay, like Shigella, right? So remember Shigella in this one. So this one, most of the time, they get it by when they come in contact with the farm animals or when they consumed uncooked beef. Okay, things like this. And the other one is diarrhea negative hemolytic uremic syndrome, which could be due to other bacterias, viruses, uh, viruses, drugs. Okay, things like this. So now, the important thing to talk here about is the pathophysiology, like why I told you we are going to discuss it in detail. Like just to tell you a little physiology of this condition. Okay. So what happens is like um, like in hemolytic uremic syndrome, is that most of the children, they present with bloody diarrhea. Okay, as you know, like E. coli can cause bloody diarrhea, and like the pathophysiology of this condition is that this bacteria, it releases uh, a toxin. Okay, now this toxin, the toxin invades and destroy the epithelial cells of the intestines. Okay, so simply when this thing is the case, what will happen? Like when the epithelium will be destroyed, so of course they will start bleeding. So the patient will present with bloody diarrhea. Okay, and of course this will occur in the diarrhea positive one, right? Not the diarrhea negative one. Now, after destroying the epithelial cells of the intestine, what happens is like the toxin, it enters the bloodstream. Okay, the toxin enters the bloodstream. Now, once it enters into the bloodstream, um, it started causing injury to endothelial cells. Now, endothelial cells, like they are everywhere, even the small vessels, okay, even in the kidneys, they are there. So, whenever like they are going to um, damage the endothelial cells of the kidney, so they will be having acute kidney injury. Okay, so whenever they are going to damage the endothelial cells of vessels or small vessels, okay, what will happen in these patients is uh, what will happen to here will be what like the endothelial cells in the small vessels, they hold many products like if you know about clotting, whenever someone get injury, so what happens like one Willebrand factor is released from the endothelial cells. Okay, so what will happen like they will start releasing uh, you can say one Willebrand factor as well as uh, platelet aggregating factor. These things are basically in the small endothelial cells of the lining of the small vessel, right? So these things will be released, right? So see, when these things will be released, what will happen? Like the platelets, which are circulating in the blood, they they will start aggregating. Okay, so when they will start aggregating, basically what they will do, like they are going to form small thrombi. Okay, and these thrombi can damage multiple multiple organs. Okay, so see what's going on. Toxin which is released, like now the toxin is in the blood, and now because that toxin is damaging the endothelial cells, so that's what is going on. And again, what kind of organs is damaged? Of course, there could be signs and symptoms of that one. For example, it could be kidneys again, it could be brain, okay, it could be uh, any other organ, okay, whatever will be damaged. So, and what will be the thing? When the platelets will start aggregating, the platelets will be consumed. Okay, so simply the patient will present with what? Thrombocytopenia. Okay, now see, these small thrombi which are in the small vessels, they are going to like damage the RBCs. So simply the RBCs will get damaged when passing through the occluded vessels. Okay, so what will happen when we will see their blood film? They will be having fragmented RBCs. Okay, so basically these fragmented RBCs are called as um, schizocytes. Okay, so these are called as what? Schizocytes. And now when of course, like these are fragmented RBCs which are not normal. So what will happen that when reticuloendothelial system will start removing these damaged RBCs, what will happen? Like it will give hemolytic anemia. Okay, so this is all the thing which is going on, and if you can understand this thing, see guys, the toxin which is released in the intestines, it is the one which have caused bloody diarrhea. It is the one which have caused organ damage, especially acute renal failure or acute kidney injury. It is the one which have consumed platelets, which will lead to thrombocytopenia, and as I told you, that the patients, they present with thrombocytopenia, acute renal failure, as well as microangiopathic hemolytic anemia. Microangiopathic means like small vessels, right? So this is the pathophysiology which is going behind, and the children, they present with the clinical features of that. Now see, this condition is so easy to understand, like if you know the pathophysiology, you can tell about the clinical features so easily that things will become easy for you. Now, first of all, see, the story started from diarrhea, right? So they present with diarrhea, especially uh, you can say bloody, right? So this is one of the feature. And now, after bloody diarrhea, what will happen that they have hemolysis going on, so they will be presenting with signs of anemia, which are paler. Okay, and now more and more RBCs are destroyed up, so bilirubin will be increased in the blood, jaundice will be there, right? So this thing, see, these things will be there, right? Now other features, because the small vessels are destroyed elsewhere in the body, so they will present with abdominal pain. Okay, so abdominal pain can be due to that, can be due to bloody diarrhea, because it is affecting the intestines. Okay, so normally, by the way, it takes like 5 to 7 days for the patient to show the signs and symptoms of anemia or thrombocytopenia. So when thrombocytopenia is there, the patient will present with petechias and purpuras. Okay, so this is how the patient present. The last thing which is there is the renal failure. So maybe the patient can present with edema, hypertension, okay, or other features of nephritic syndrome, right? Now, guys, like I already included nephrotic syndrome in the playlist of the pediatrics, and you can see the lectures from there. Okay, so these are the things, how um, the patient of hemolytic uremic syndrome they present with. Okay, and if you know like the pathophysiology, that's why I told you the things are quite easy for you. You can see over here I included this one. Now many people who present with thrombotic microangiopathy. All right, let me remove that. Thrombotic microangiopathy, like there is thrombocytopenia, hemolytic anemia, kidney failure, involvement of other organs, including cardiovascular and neurological findings. So see, we know this thing, right? Now, there is something called as thrombotic thrombocytopenic purpura. Okay, and so there are different causes of thrombotic microangiopathy. It could be this, it could be this, it could be other systemic conditions, right? So hemolytic uremic syndrome is written over here. What are the investigations you have to do in these patients is quite easy. Again, if you know the pathophysiology, the investigations is easy for you to do, and the things will be easy. Of course, like you will get a history, like the things which will lead us to the diagnosis of this condition is, in the history we will found that the patient have the history of some bloody diarrhea or diarrhea, right? And then CBC can be done. CBC will show anemia as well as thrombocytopenia. Okay, if you will do the peripheral film of the blood, you will find schistocytes. Okay. Now remember, guys, when the kidneys are involved, in any case, we will also go for urine examination. Okay, we will also go for kidney functions testing. Okay, we will always go for electrolytes because now the kidneys are damaged, so of course we have to check them. Okay. Now diarrhea is there, you can go for stool examination or stool culture to see what kind of organism is there. Okay, so see, like all these investigations can be done. Rest is depending on the clinical features. If there is other organs which are involved, we will go and do testings related to that. Okay, the management of this condition is quite, you can say, different in some regards. I will tell you why it is different. Now, see, there is microangiopathic hemolytic anemia going on. There is renal injury going on. There is thrombocytopenia going on. So, first of all, the management is mainly supportive. Okay, we take care of their hydration, very important. Their nutrition, okay, also very important. Take care of their electrolytes. Okay, so of course, like these things are done. If the patient is too much anemic, we can go for blood transfusion. Okay. Now, guys, remember, if the kidneys are too much damaged, like they are not functioning there properly, and there is any indication for hemodialysis, for example, like hyperkalemia is one of the indication. Um, uh, One of the indication is if there is um, pericarditis and things like this, if the level of the urea and creatinine are increasing too much, so dialysis for that. Okay, so of course, like if there is any indication for dialysis, we'll go for that. Okay, or for example, if the fluid overload is it cannot be corrected, or whatever you are giving, like you are giving diuretics and things like this, but they are not helping, so we will go for dialysis. So remember this thing that it is mainly supportive. I told you this thing because steroids are not helpful in this condition. Okay, so even if we will give steroids, there is nothing like this that steroids are going to suppress the immunity or things like this. No. And one very important thing to remember is antibiotics are contraindicated. This is the most important point. Why antibiotics are contraindicated? Because if you will give antibiotics to these patients, antibiotics are going to kill more and more bacteria, and when antibiotics are going to kill more and more bacteria, there will be more and more toxin which will be released, and simply the picture of the patient or the condition of the patient will become worse. Okay, so antibiotics can make the condition even worse. or can make the clinical status of the patient even worse. Okay, so why we are studying this condition? Because this is the most common cause of acute kidney injury in the children. And to tell you about this one, uh, the children who have hemolytic uremic syndrome, up to 25% of them, they can go into long-term renal damage, or they can lead to long-term renal failure, you can say. Okay, so you can say like this: 25 up to 25%, uh, up to 25% of children, they may have long-term renal damage. Like, what is long-term renal damage? Of course, like they will be having hypertension, they will be having proteinuria, they will be having decreased renal function. So of course, like, we have to treat them. Okay, so uh, this is how we treat them, right? This is how we treat these patients, and this is what we do. So now, guys, like, remember, hypertension in children is not the same as what we define the hypertension in adults. Rather, the definition of hypertension is different. Okay, so hypertension uh, in children is different from adults. Okay, so there are different books which gives different definitions, like, simply because there are different guidelines which are available in this world. So one of the thing is like, maybe we can found it. I can show you over here if I'm found it. We have the charts available, or you can say 95th percentile. Wait, percentile blood pressure beats. Yes. So basically, we have charts like this available. You can see over here. Okay, or this one. Okay. So many are available. Or like this one. This one is half cut. But what is this one like? In the boys, this is for the boys and this is for the girls. Okay, so basically we have a chart like this, and if you will see, for example, if I will show you this one, the systolic and diastolic, they have written age. So if you will see like 1 year of age, see the systolic, uh, most of them, their systolic blood pressure is like around this much, 50 percentile. And see uh, the 95th percentile line, right? And this is for the diastolic blood pressure. So we have a charts like this. Okay, so simply hypertension in the children, this is mostly diagnosed or defined on the percentile chart. So hypertension in children is defined when the systolic blood pressure or or diastolic blood pressure um, is equal or greater than 95th percentile for sex or age or height. Okay, on 3 or more than 3 occasions. Okay, so see, this is how we diagnose. So as I told you, like, there is, like, this one is regarding age, and then there is charts for wait, there are charts for height. This one is height based, right? This one is wait, this one is for height. Okay, so height percentile. Okay, so simply you can say that depending on how what you are doing is like, when the systolic or diastolic blood pressure is equal or greater than the 95 percentile for sex, age, height, or on 3 or more than 3 occasions. So now, and pre-hypertension is simply when it is more than 90. Okay, so simply you can say, if you will just copy this one, sorry, if I just copy this one, I don't know like how to copy it. Okay, so okay, so if you will remove it and make it 90, it will become the definition for pre-hypertension. Okay, pre-hypertension definition. It will become the definition for pre-hypertension. Okay, in the kids. So now one of the thing which is completely acceptable or which is well established, like of course, like blood pressure of 120/80 or more than that is hypertension in pediatrics. Okay, so irrespective of the age, sex, whatever, right? This will be hypertension. So why I started this topic, because I told you like up to 25% they go into long-term renal damage, so they present in this way. They present with hypertension. They present with all these things, and of course this will be like the secondary cause of hypertension, because in the kids, again, whenever we talk about hypertension, we classify it according to this primary or secondary, and secondary one have a lot of causes. For example, it could be anything like coarctation of aorta, congenital renal disease, pheochromocytoma, corticosteroid use, Cushing syndrome, same things like adults, right? Uh, but and if you have done the hypertension in adults, of course, it is no different than the adults, if when it comes to the causes. But like regarding treatment management, there of course there is some difference. Okay. Now the important thing is like hypertension in the kids, or in the children is not too much researched area, but they use the normal what you can say drugs which have the least side effects, like it could be thiazide diuretics or stuff like this. They use in this one. One of the way to calculate the pediatric blood pressure is by using a formula for systolic and the diastolic blood pressure. Is for the systolic blood pressure, it is age multiplied by 2 plus 90. Okay, and for diastolic blood pressure, it is 2 by 3 multiplied by systolic blood pressure. Okay, so this is like one of the way to calculate the diastolic as well as systolic blood pressure in children. Okay, rest like nephrotic and nephritic syndrome, they are same as we have already done in adults. I have added the slides for nephrotic and nephritic syndrome in pediatric playlist, like you can see that. And of course, like in that one I talk about this thing, like what are the causes of nephrotic, what are the causes of nephritic, right? Like the most common cause of nephritic syndrome in children is we like in like which I already talked about in the previous lecture, called as PSGN or post-streptococcal glomerulonephritis. And the most common cause of nephrotic syndrome in children is basically what you can say MCD or minimal change disease. So remember, post-streptococcal glomerulonephritis is the most common cause of nephritic syndrome, whereas minimal change disease MCD is the most common cause of nephrotic syndrome in children. So the rest, everything is same. There is no difference. Okay, even the management is somehow same. So thank you so much, guys, for listening to this lecture. We'll see you in the next lecture.